Hey, welcome back to Not So Complicated, and today we are starting a new series where we study USMLE First Aid 2025 line to line. And here I present myself as your motivated study partner. Let's begin. And today we are starting from high yield principles in pathology. It's of general pathology, and we are covering up cellular injury in today's topic. Let's begin. So, what is a cellular injury? Cellular injury is basically any insult, potentially a reversible or maybe irreversible change in response to the environment is cellular injury, right? So, cellular adaptations can be reversible, that can be physiologic, right? Reversible changes that can be physiologic or pathologic, like myocardial hypertrophy secondary to systemic hypertension, can be the cellular adaptations for examples, right? And if the stress is excessive or persistent, adaptations can progress to the cell injury. So the cell injury is the later fate of cellular adaptations if the body cannot further adapt or work out the insult provided by the environment, right? So basically the cellular adaptations are of different types. This can be a cellular hypertrophy or something like that, and I'm also using Kaplan notes as resources, so I will be reading from that too. And if you have any other resources, you can take notes from that too. And remember that I am not your tutor or something like that. We are just studying together, and I am trying to keep myself motivated, and you will try to keep yourself motivated from this, right? So hypertrophy means increase in structural proteins and organelles, which leads to the increase in size of cells. And the example includes cardiac hypertrophy, right? So hypertrophy is an increase in cell size and functional ability due to increased synthesis of intracellular components, right? And the causes of hypertrophy can be two things can happen to lead to the hypertrophy, and it can either be increased mechanical demand, which can be physiologic or pathologic, and also it can either or be increased endocrine stimulation also plays role in hypertrophy. For example, in puberty, growth hormones, androgens or estrogens, and in gravid uterus, the estrogen plays role in hypertrophy, and also in lactating breast, prolactin and estrogen plays the role. And also hypertrophy is mediated by growth factors and cytokines and other trophic stimuli too. So basically that is all about hypertrophy. And in hyperplasia, there is controlled proliferation of stem cells and differentiated cells. Obviously there should be controlled proliferation, because uncontrolled proliferation obviously leans us towards the tumor, right? Whether it's malignant or benign. But benign tumor can also be considered as hyperplastic, because for example, benign prostatic hyperplasia is also just hyperplasia, right? And excessive stimulation causes pathological hyperplasia, which can be endometrial hyperplasia, which may progress to dysplasia and cancer. So basically, the thing about hyperplasia is that the fate of hyperplasia is that excessive stimulation causes hyperplasia, which may lead to dysplasia and also lead to cancer, right? And the physiological causes of hyperplasia include compensatory mechanisms. For example, we can take the liver, right? We can take liver, and the liver, like this is a liver, right? And this liver, in a hepatectomy, we cut a portion out of it, because for example, imagine there is a cirrhosis or liver nodules in here, and we cut the livers and thus reject it out, right? And the remaining liver is this. But with time, what happens is that the liver compensates from hyperplasia to become the old one, or to become a new one with a similar shape or similar size. That is a real case of hyperplasia, right? And also hyperplasia is mediated by growth factors, cytokines and other trophic stimuli, like increased expression of growth promoting genes, proto-oncogenes, and increased DNA synthesis and cell division. So let's go to our atrophy. And atrophy is the decrease in tissue mass due to decrease in size. Decrease in tissue mass due to decrease in size and cytoskeleton degradation, because the size decrease decreases due to cytoskeleton degradation by a ubiquitin proteasome pathway and autophagy. These two are very high yield and very important for our USMLE Step 1, because I have seen a lot of questions. I have found and solved a lot of questions for this, and this leads to decrease in protein synthesis and our number of cells, causing apoptosis. Apoptosis is programmed cell death without inflammation. We'll talk about it later. And the causes include disuse, denervation, and loss of blood supply, loss of hormonal stimulation, poor nutrition. That are the causes of atrophy. For example, we can take the disuse is the cause of atrophy. For example, this is a muscle fiber, right? And there is a nerve supplying this muscle. So if we did the denervation of this muscle fiber, then the muscle fiber atrophies, because it cannot function. Even if the blood vessels are supplying nutritions to this muscle, it cannot function, and it is non-functional or dysfunctional, which with time becomes atrophied. That is the case in atrophy. And the metaplasia is reprogramming of stem cells, replacement of one cell type by another that can adapt to a new stressor. It is basically because some example, just like if the insult of the environment is not capable, if a cell is not capable to counteract the insult of an environment, it chooses a new stronger cell for itself to counteract and compensate the injury, right? And that is why metaplasia occurs, usually due to exposure to an irritant, just as gastric acid, esophageal epithelium replaced by intestinal epithelium called Barrett's esophagus. Barrett's esophagus, we will talk about that in systemic pathology. Barrett's esophagus is normally the risk factor, the complication of GERD. And obviously there are two types of Barrett's esophagus. This is long segment or short segment, less than 3 centimeter, more than 3 centimeter. It is red velvety tongue like structure in endoscopy. That is all in systemic pathology. Or tobacco smoke, let's say respiratory ciliated columnar epithelium gets replaced by stratified squamous epithelium. That is also because of the insult, and they may progress to dysplasia, leading to malignant transformation with persistent insult. Barrett's esophagus to esophageal adenocarcinoma is a very famous example of this. And metaplasia of connective tissue can also occur, causing myositis ossificans and the formation of bone within muscle after trauma. So what's dysplasia? Dysplasia is something more than normal but less than cancer, right? That is dysplasia. And dysplasia is disorder of precancerous epithelial cell growth, not considered a true adaptive response, because it leans towards pathological case instead of physiology. So it is not considered as a true adaptive mechanism in normal. So it is characterized by loss of uniformity of cell size and shape, called pleomorphism, and loss of tissue orientation, nuclear senses. Example, increase in nucleocytoplasmic ratio and clumped chromatin, which is a typical features of malignancy or tumor or neoplasia that we say. And also mild and moderate dysplasias, that is, do not involve entire thickness of epithelium, may regress with alleviation of inciting cause. And also severe dysplasia often becomes irreversible and progress to carcinoma in situ, usually preceded by persistent metaplasia or pathologic hyperplasia. And hyperplasia, hypertrophy, atrophy, as we can see in the figure, these are hyperplasia, hypertrophy, and atrophy. And if they are inability to adapt, they cause irreversible cell injury, which is necrosis or apoptosis, right? And if they change in cell size and number, normal, that is normal cells, that normal cells also, if severe stressor injury, they do not go in this pathway, but they directly go in this pathway, right? And that is why the adaptation is required. So basically, if normal cells increase in size to adapt to the environment like this, but if they cannot adapt, they go to this pathway. And also the normal cells change in cell structure causing dysplasia, change in cell type causing metaplasia, and also change in cell type and structure, which is neoplasia. This is the very risky thing that happens, and if chronic irritant persists, all of this dysplasia and metaplasia also gets converted to the neoplasia. That is, the red lines here are irreversible and the green lines are reversible. These changes here are reversible, right? But this red line changes are very much irreversible, but because we all know that a neoplasia cannot be reversed, right? So cell injury are basically two types of cell injury. There are the reversible cell injury and irreversible cell injury, right? Cell injury leads to cell death. That is what we will talk later in apoptosis and necrosis, the types of necrosis. So what is a reversible cell injury? Reversible cell injury, it decrease in ATP leads to decreased activity of calcium and sodium potassium ATPase pumps, causing cellular swelling, cytosol, mitochondria, endoplasmic reticulum, Golgi, which is the earliest morphologic manifestation of reversible cell injury. So, ribosomal or polysomal detachment leads to decrease in protein synthesis, plasma membrane changes, which is blaving. We call it blaving, right? Plasma membrane change is called blaving, and nuclear changes causes chromatin clumping too. And rapid loss of function. Myocardial cells are non-contractile after 1 to 2 minutes of ischemia, which is in the ischemic heart disease. We will talk in systemic pathology, where we talk about acute myocardial infarction and also myelin figures, aggregation of peroxidized lipids, right? So peroxidized lipids, which means that the if any insult occurs, there actually appears to be the reactive oxygen species, and these reactive oxygen species cause the peroxidation of lipids and oxidation of fats, right? And that will cause the aggregation. This aggregation of myelin figures cause reversible cell injury. And the reversible means these injuries can be reversed back to the normal, and the injuries and all of these things can be back to be normal if we do it right. And but the irreversible cell injury, it cannot be gone back to the normal, and the breakdown of plasma membrane, cytosolic enzymes, troponin leak outside of the cell, influx of calcium, activation of degradative enzymes, all of this is in so much flowchart, so fluidity, we can understand it so very well. So mitochondrial damage or dysfunction, since mitochondria is the powerhouse of the cell, we have been hearing that from a lot of years, right? And that causes loss of electron transport and decrease in ATP, and since ATP is the one that is keeping us alive, this also causes the changes in cell integrity. And also the rupture of lysosomes causes autolysis, because since rupture of lysosomes normally have autophagic enzymes, right? Lysosomal enzymes are autophagic, and they cause, in fact, the lysosomes are used to remove the necrotic debris or external agents like bacteria and something like that. But if it is attacking our one cells, our one tissue, it is causing autolysis, and that is why the irreversible cell injury occurs. And nuclear degradation, which is pycnosis means nuclear condensation, and also karyorrhexis means nuclear fragmentation, and karyolysis means nuclear dissolution. These three things are very important in step 1, because I have also seen the questions in these things. Nuclear condensation is pycnosis, nuclear fragmentation is karyorrhexis, and nuclear dissolution is karyolysis. And also amorphous densities are inclusions in mitochondria. So normal cell in our figure right here is the normal cell. Again, the indication is irreversible in red lines, and reversible in green lines and black lines. So cell death, which is necrosis. So normal cell here is, in the first changes are cellular swelling, ribosomal detachment, membrane blebbing, nuclear chromatin clumping. These are the first senses. So if a question arises, which are the first senses in the cellular injury, we have to remember these points, these actual points here, and then that progresses into rupture of lysosomes and autolysis, plasma membrane damage, nuclear degradation, increased mitochondrial permeability, and finally this is the cell death, and it is causing necrotic debris in here. All of these are the debris, right? So that is what about cellular injury. And if the cellular injury doesn't get removed up, it leads to cell death. And cell death are of two types, right? Those are apoptosis and necrosis. Apoptosis is programmed cell death, and also what is programmed cell death? It is a specialized form of programmed cell death without an inflammatory response. There is no any inflammatory response. It is ATP dependent, right? And for this to happen, there are two pathways: intrinsic pathways and extrinsic pathways. These are very important, and the gene associated in here are very much asked. And intrinsic, extrinsic, and porphyrin or granzyme B pathways activate caspases, which are cytosolic proteases. Proteases means the enzymes that degrade or that eat up proteins. These are proteases. So activate caspases, and since everything is made up of protein in our body, the cellular breakdown, including cell shrinkage and chromatin condensation, membrane blebbing, and formation of apoptotic bodies does occur, which are then phagocytosed, right? And it is characterized by deeply eosinophilic cytoplasm and basophilic nucleus, pycnosis, karyorrhexis. As we talked about karyorrhexis means nuclear fragmentation, and as we talked about pycnosis, it is nuclear condensation, right? And then cell membrane typically remains intact without significant inflammation, unlike necrosis, because necrosis is associated with inflammation. And then DNA laddering, this is such a term, right? DNA laddering means fragments in multiples of 180 bp is a sensitive indicator of apoptosis. Okay, this is a high yield point. We have to remember this. This is a very much high yield. Okay, and the pathway, let's go into these three pathways: intrinsic, extrinsic, and porphyrin or granzyme B pathway. Intrinsic pathway, mitochondrial pathway, involved in tissue remodeling in embryogenesis, occurs when a regulating factor is withdrawn from a proliferating cell population. Example, decreased interleukin 2 after a completed immunologic reaction causes apoptosis of proliferating effector cells. Also occurs after exposure to injurious stimuli, example radiation, toxins, and hypoxia, right? Okay, so this is regulated by BCL2 family of proteins. BCL2 family of proteins, right? BAX and BAC are pro-apoptotic, which are bad for survival, while BCL2 and BCL-XL are anti-apoptotic, B clever, live. So there is a mnemonic in here: BAX, BAC. First we have to remember four genes, right? BAX, BAC, BCL2, and BCL-XL. So BAX and BAC, we have BA and BA, and also BA in bad for survival. So BAX and BAC are pro-apoptotic, which are bad for survival, and BCL2, BCL2. Let's split that up. B, but BE and clever, B clever and live. So BCL2 and BCL-XL are anti-apoptotic, so B clever and live. That is it, right? It is so nice. So BAX and BAC form pores in the mitochondrial membranes, and this causes release of cytochrome C from inner mitochondrial membrane into the cytoplasm and activation of caspases. BCL2 keeps the mitochondrial membrane impermeable, thereby preventing cytochrome C release. Obviously, since they are opposite, one is pro-apoptotic, one is anti-apoptotic, they should do the work that are opposite. Also, BCL2 overexpression causes follicular lymphomas. Not everything has a good function, right? So BCL2 is an anti-apoptotic, but if it is overexpressed, it causes follicular lymphoma. In follicular lymphoma, there occurs the genetic mutation, which is translocation of chromosome 14 to 18, and this decreases caspase activation, causing tumorigenesis. That is what happens in intrinsic mitochondrial pathway. And an extrinsic death receptor pathway, there is ligand receptor interactions, FAS-L binding to FAS, which is CD95, but TNF alpha binding to its receptor. FAS-L interaction is necessary in thymic medullary negative selection. So autoimmune lymphoproliferative syndrome caused by defective FAS-L interaction, failure of clonal direction, increased number of self-reacting lymphocytes. This is such a wonderful concept that if there are these pathways here are meant to kill the cells, but if they are overexpressed, right, if the genes of these pathways are defective, then it causes tumorigenesis. This is such a nice concept in here, right? And it presents with lymphadenopathy, hepatosplenomegaly, autoimmune cytopenias. And porphyrin granzyme B pathway, it causes release of granules containing porphyrin and granzyme B by immune cells, cytotoxic T cell, and natural killer cells. So porphyrin forms a pore for granzyme B to enter the target cells. So there is a figure in here, right? The figure in here, intrinsic pathway, which is mitochondrial, and extrinsic pathway is from death receptor. So DNA damage caused by radiation, reactive oxygen species are toxins, misfolded proteins. Hypoxia causes P53 activation, and P53 is a gene which activates Bax and BAC, and it is inhibited by BCL2 gene because it is an anti-apoptotic gene, and this causes cytochrome C to be released, and executioner caspases are released. These executioner caspases then cause cytoskeletal dispersion, and this causes cytoplasmic bleed. And here the extrinsic pathway, death receptor, TNF alpha and TNF receptor, or FAS-L and FAS receptor, causes executioner caspases, and also granzyme B, porphyrin released granzyme B. These all cause nuclear fragmentation, right? And this nuclear fragmentation then causes to the apoptic body formation. The apoptic body formation is then engulfed by macrophages. So ligands for macrophage cell or receptors are there in the apoptic body, so they are engulfed by macrophages, and thus the clearing occurs. That is what about the cell death in apoptosis. That is what it's all about. And there is necrosis here. This is another type of cell death, but it is associated with inflammation, and it occurs due to plasma membrane damage, exogenous injury causing plasma membrane damage to intracellular components leak out. Then cell goes enzymatic degradation and protein denaturation, and these released proteins cause local inflammatory reaction, unlike apoptosis. That is what it happens. The proteins, the cellular debris that is released causes inflammatory reactions, right? So there are types of necrosis: coagulative, liquefactive, caseous, fat, fibrinoid, gangrenous necrosis. There are a lot of types of necrosis. Let's go to each of them. So coagulative necrosis is seen in ischemia or infarction in most tissues except brain, right? It is not seen in brain. So since brain is a highly oxygenated organ, the ischemia occurs in here very rarely, right? And due to ischemia or infarction, injury denatures enzymes, and proteolysis, which proteolysis is blocked. So that is what it happens here. So proteolysis is blocked. And in histology of coagulative necrosis, we can see preserved cellular architecture. Cell outlines are seen, but nuclei disappears. And increased cytoplasmic binding of eosin stain, increase in eosinophilia, red or pink color. That is what it happens. The cellular architecture is preserved. That is what we need to remember in here. Coagulative necrosis is common in most organs, including the heart, liver, and brain, but not heart, liver, and kidney, but not the brain, right? So in liquefactive necrosis, the causes they are seen in CNS infarcts or bacterial abscesses, and this is due to neutrophils release or lysosomal enzymes that digest the tissues. That is a real thing, and also they result from hydrolytic enzymes leading to autolysis, release of proteolytic enzymes from injured cells, and heterolysis, release of proteolytic enzymes from inflammatory cells. So there are two types of lysis, right? The one is autolysis, which is due to release of proteolytic enzymes from injured cells, and heterolysis, which is from release of proteolytic enzymes from inflammatory cells. That is the difference. And liquefaction necrosis occurs in abscesses, brain infarcts, and also in pancreatic necrosis. So in histology, early histology, we can see cellular debris and macrophages, but in late, cystic spaces and cavitation are seen in CNS, and neutrophils and cell debris seen with bacterial infection, right? So in another type of necrosis here is caseous necrosis. This is TB, systemic fungi, histoplasma capsulatum, nocardia. They are seen in this. Caseous necrosis is in all this kind of necrosis, the most common type of necrosis is coagulative necrosis, and it is most often due to ischemic injury. This is high yield, so you must not forget that. And the caseous necrosis is a combination of coagulation necrosis and liquefaction necrosis as a whole. So the insult here is histoplasma capsulatum and nocardia, and also this occurs due to macrophages wall off the infecting microorganisms, granular debris, that is what it occurs, and also fragmented cells and debris surrounded by lymphocytes and macrophages are simply granuloma is formed. Example is tuberculosis. In tuberculosis, we can see caseous necrosis, which is cheese-like gross appearance. That is what it happens. We can remember it off. So caseous necrosis means, tuberculosis means caseous necrosis. Just remember that. Caseous necrosis is seen in tuberculosis. Okay. So cheese-like, soft, friable, gross appearance is there. Another necrosis here is fat necrosis, which can be enzymatic and non-enzymatic. Enzymatic fat necrosis normally occurs in acute pancreatitis due to saponification of peripancreatic fat, and non-enzymatic due to trauma, example injury to breast tissue. And this occurs due to damaged pancreatic cells release lipase, which breaks down triglyceride, obviously, because the function of lipase is to break down triglycerides. Liberated fatty acids then bind to calcium, saponification, white chalky appearance thus occurs. So since the calcium is binding to fatty acids and causing saponification here, the blood serum level of calcium is decreased, so causing hypocalcemia. So basically fat necrosis is normally associated with hypocalcemia. Outlines of dead fat cells without peripheral nuclei. This is our histological finding. And saponification of fat combined with calcium appears dark blue on HN stain. So dark blue on HN stain. This is also high yield, right? This is also high yield. Fat necrosis appears dark blue in HNE stain. This is high yield. And also the fibrinoid necrosis. It may be due to immune vascular reactions like polyarteritis nodosa, or non-immune vascular reactions as in hypertensive emergency and preeclampsia. These are also two types: immune vascular reactions and non-immune vascular reactions, and this is due to deposition of immune complex type 3 hypersensitivity reaction and or plasma protein fibrin leakage from damaged vessel. This occurs in this, and it is a form of necrotic connective tissue that histologically resembles fibrin. And on microscopic examination, fibrinoid necrosis has an eosinophilic, which is pink homogeneous layer, eosinophilic layer, but it is homogeneous in nature, right? And also it is often due to acute immunologic injury. Obviously we have talked about that. And the last one here is gangrenous necrosis, distal extremity and GI tract after chronic ischemia that happens in gangrene. And in dry gangrenous ischemia, this is due to ischemia obviously, and weight is due to superinfection. And dry ischemia is seen as coagulative, and weight is seen as liquefactive, superimposed, and coagulative. So this here is our caseous necrosis in here, these necrotic areas, and this debris here we can see here the debris, right? So, and in gross examination we can see here the liquefactive necrosis in brain. This is causing brain infarct right here. And here is our caseous necrosis. And also here is our fat necrosis. These fat globules we can see here, these are the fat globules, right? And this is our fat necrosis. And the fibrinoid necrosis, this is the deposition of fibrin right here. And these are inflammatory cells, mononucleocytes, leukocytes, we can see everything in here. And this is gangrene of extremities, this is gangrenous, right? So dry gangrene has coagulative necrosis and microscopic pattern, as we talked earlier. Wet gangrene has liquefactive necrosis, right? So necrotic tissue within the body usually evokes an inflammatory response that removes the dead tissue and is followed by healing and tissue repair. And necrotic debris may also undergo dystrophic calcification, which we will talk about that later. And that is it. So liquefaction by leukocyte enzymes is called suppuration. So what is suppuration? Suppuration is liquefaction but by leukocytic enzymes, right? So leukocytic enzymes causing liquefactive necrosis is suppuration, and the resultant is called pus. The resultant is pus. The pus is the resultant. And that is what happens if the leukocyte causes liquefaction, right? So let's go in the ischemia. What is ischemia? Maybe we all know about ischemia. And inadequate blood supply to meet demand is ischemia. Mechanisms include decreased arterial perfusion, example atherosclerosis, or decreased venous drainage, testicular torsion, Bursari syndrome, shock. That can happen, obviously. And reasons most vulnerable to hypoxia or ischemia and subsequent infarction is brain. At first point is brain, because even if the oxygen supply is cut off for 2 minutes, the infarction begins in brain. That is why this is very much important. And in anterior cerebral artery, middle cerebral artery, posterior cerebral artery boundary areas, this is seen in most common. So these are the most susceptible regions. And also in heart, a subendocardium of left ventricle, aligns in figure A. This is the subendocardium level, right? This is the reason. And that is what happens in here. So basically in kidney, straight segmental proximal tubule, medulla, thick ascending limb, medulla, these are the most susceptible regions. And in liver, area around central vein, zone 3 is the most susceptible region. And colon, splenic flexor, Griffith point or rectosigmoid junction, Sudeck point. Okay, these are very much susceptible. Splenic flexor, which is Griffith point, and rectosigmoid junction, which is Sudeck point. And watershed areas, border zones receive blood supply from most distal branches of 2 arteries with limited collateral vascularity. These areas are susceptible to ischemia from hypoperfusion. So watershed areas, right? These watershed areas are the border zones that receive blood supply from most distal branches of 2 arteries with limited collateral vascularity. Example is the umbilical region. In umbilical region, there are watershed areas, and these are very highly susceptible for ischemia from hypoperfusion. And also neurons most vulnerable to hypoxic ischemic insults include Purkinje cells of the cerebellum and pyramidal cells of hippocampus and neocortex, layers 3, 5, 6. These are most highly vulnerable for insult, right? So we have to remember Purkinje cells of cerebellum and pyramidal cells of hippocampus and neocortex are most highly vulnerable. And the types of infarcts are red infarct and pale infarct, or white infarct, we can say that too. And red infarct occurs in venous occlusion and tissues with multiple blood supplies, example liver, lung, intestine, testes, and with reperfusion after angioplasty. Reperfusion injury is due to the damage by free radicals. So red infarct normally occurs in reperfusion injury. The reperfusion injury, the mechanism of reperfusion injury, we will talk about that in systemic pathology, in our myocardial infarction thing, in our ischemic heart disease thing. And these right here are these the area of red infarct right here, right? And the pale infarct occurs in solid organs with single blood supply, example heart. This is the kidney region here, right? That caused it. That's it. So the types of infarct and free radical injury. Free radicals damage cells by membrane lipid peroxidation. I talked about it earlier, right? So free radicals means superoxides, or the oxygen reactive oxygen species. They cause oxidation and peroxidation of the membranes. So they cause membrane lipid peroxidation, protein modification, DNA breakage. They all are caused by free radicals and initiated by radiation exposure. Example, cancer therapy, metabolism of drugs in phase 1, redox reactions, nitric oxide inflammation, transition metals causing iron, copper form free radicals by a Fenton reaction. WBC example, neutrophils, macrophages, oxidative burst, right? These all are due to free radical. These are the causes of free radical injury. And also free radicals can be eliminated by scavenging enzymes called catalase, superoxide dismutase, glutathione peroxidase, spontaneous decay, antioxidants, and also certain metal carrier proteins called transferrin and ceruloplasmin. This can be eliminated, obviously. And the examples are oxygen toxicity, retinopathy of prematurity, abnormal vascularization, and the bronchopulmonary dysplasia, reperfusion injury after thrombolytic therapy. These all are examples of free radical injury. This even see how vital is oxygen for our survival, but yet it can cause toxicity to us. And drug or chemical toxicity right here, acetaminophen overdose, hepatotoxicity, carbon tetrachloride converted enzyme cytochrome P450 into CCl3 free radical, which causes fatty liver cell injury, decrease in apolipoprotein synthesis, fatty chains, and centrilobular necrosis. So basically carbon tetrachloride, which is converted by cytochrome P450 into CCl3 free radical, causes fatty liver cell injury and fatty chains, centrilobular necrosis also. So metal storage diseases like hemochromatosis, iron, and Wilson's disease, copper also cause free radical injury. And there is another thing here, which is ionizing radiation toxicity. Ionizing radiation causes the DNA, example double strand breaks, and cellular damage both directly and indirectly through the production of free radicals. Complications usually arise when patient is exposed to significant doses, example radiotherapy, nuclear reactor accidents, and these are via localized inflammation and fibrosis. Also in neoplasia, example leukemia or thyroid cancer. In an acute radiation syndrome, this is very high yield, and in acute radiation syndrome develops after sudden whole body exposure to high doses of ionizing radiation, causing nausea, vomiting, diarrhea, hair loss, erythema, cytopenias, headache, altered mental status. This acute radiation syndrome can cause in nuclear holocaust or something. Regenerating tissues, example skin, bone marrow, GI tract, gonads are the most susceptible to radiation injury. So basically, if the X-rays or MRIs are overly loaded in these cells, this can cause the radiation injury in long term. And also radiotherapy damages cancer cells more than healthy cells, because cancer cells have dysfunctional DNA repair mechanism. This is the point right here. This is the point we need to remember. Obviously, the radiation damages both healthy cells and cancer cells, but it damages more cancer cells more than healthy cells, because cancer cells have dysfunctional DNA repair mechanisms in addition to high replicative rates. That is why it happens. And also the types of calcification. The calcification occurs in, there are two types of calcification, dystrophic calcification and metastatic calcification, right? So dystrophic calcification means calcium deposition in abnormal diseased tissues. D for dystrophic, D for diseased tissues. That is what we have to remember. And metastatic calcification occurs in normal tissues. This is quite rare. And the extent of dystrophic calcification tends to be localized. Example, calcific aortic stenosis, it is localized normally, but metastatic, since the name is metastasis, obviously it means spreading, widespread, that is diffuse and metastatic. And associated conditions of dystrophic calcification are TB, lung and pericardium, and other granulomatous inflammation, infections, liquefactive necrosis of chronic abscess, fatty necrosis and infarcts, thrombi, schistosomiasis, congenital CMB, toxoplasmosis, rubella, Psammoma bodies. These Psammoma bodies are very important. We will talk about it later. And Crest syndrome, atherosclerotic plaques can become calcified. These all lead to dystrophic calcification, which is that we have to remember this causes dystrophic calcification, because this is seen in USMLE Step 1 questions, very much common. Often these are associated, and the etiology is secondary to injury or necrosis, right? And in metastatic calcification, it is predominantly in interstitial tissues of kidney, lung, and gastric mucosa. And these tissues lose acid quickly, increased pH favors calcium deposition, and nephrocalcinosis of collecting ducts may lead to nephrogenic diabetes insipidus and renal failure. So these occur due to secondary to hyperphosphatemia, example in chronic kidney disease, or hypercalcemia, example hyperparathyroidism, or sarcoidosis and hypervitaminosis D. These are the causes. These all causes are very high yield. We have to remember, as we talked about Psammoma bodies earlier, we have mnemonics here. Psammoma bodies are concentrically laminated calcified spherules. We have to remember this, right? And the mnemonics here is Psammoma. Psammoma's mnemonics is Psammoma itself. Psammoma, P, usually seen in certain types of tumors. Psammoma's P for papillary carcinoma of thyroid gland and kidney. And then S for somatostatinoma. And for M, meningioma, mesothelioma, ovarian serous papillary cystadenocarcinoma, and in milk, which is a prolactinoma. That is what is about Psammoma bodies. P, papillary carcinoma of thyroid and kidney, somatostatinoma, meningioma, mesothelioma, and ovarian serous papillary cystadenocarcinoma, milk, prolactinoma. In histology, basophilic staining of calcium deposits within tissues occurs. That is what it happens. Basophilic staining occurs. So here this arrow here, this is basophilic staining. These are Psammoma bodies in here. These are Psammoma bodies. We have to remember that. And amyloidosis. Amyloidosis is the extracellular deposition of protein in abnormal fibrillar form, that is beta pleated sheet configuration, causing cellular injury and apoptosis. Manifestations vary depending on involved organ and include renal or nephrotic syndrome, cardiac restrictive renal nephrotic syndrome, cardiac restrictive cardiomyopathy, GI hepatosplenomegaly, and also neurologic peripheral neuropathy, and the musculoskeletal system, muscular enlargement in macroglossia, carpal tunnel syndrome, and skin waxy thickening, easy bruising occurs, and amyloid deposits are visualized by Congo red stain. This stain we have to remember, Congo red stain. Congo red strain, we have to remember that. And red or orange in non-polarized light, apple green birefringence and polarized light. How does it look like? Apple green birefringence and polarized light, we have to remember this. And in HNE stain we see amorphous pink. We have to remember this one more, because this is a very high yield thing in here. And the common types of amyloidosis are systemic and localized. And in systemic primary amyloidosis, the fibril protein here is in AL from Ig light sense, and seen in plasma cell dyscrasias called multiple myeloma. These are seen in multiple myeloma cases. And secondary amyloidosis, AA, serum amyloid A, and seen in chronic inflammatory conditions, rheumatoid arthritis, IBD, familial Mediterranean fever, protracted infection, and transthyretin amyloidosis. Transthyretin is the fibril protein in here, and this can be of two types, which is sporadic and hereditary. Sporadic is wild type TTR, slowly progressive, associated with aging, mainly affects the heart. and the another one is familial amyloid polyneuropathy and slash cardiomyopathy. And dialysis related amyloidosis, the fibril protein is beta 2 microglobulin. So in systemic we have four types. These are primary amyloidosis, secondary amyloidosis, transthyretin amyloidosis, and dialysis related amyloidosis. And in localized we have Alzheimer's disease, which is the most common in here, and beta amyloid protein is the fibril protein which gets deposited and cleaved from amyloid precursor protein. This is what it happens. And isolated atrial amyloidosis, ANP, ANP is that is what it is, and common associated with aging, increased risk for atrial fibrillation occurs. And type 2 diabetes mellitus, islet amyloid polypeptide is it, and caused by deposition of amylin in pancreatic islets. These all things are, we have to write it up, right? We have to make a concept out of it. This is all we have to remember. These fibril proteins, these are very high yield. And medullary thyroid carcinoma, this is calcitonin secreted from tumor cells. This right here, this transthyretin amyloidosis, and this primary amyloidosis, this Alzheimer's disease, and isolated atrial amyloidosis, these all are very important high yield things. So section 2 is information. We'll cover it up in our next video, and until then we have completed our first session of reading USMLE first aid line to line, and I hope you enjoyed it. And if you have any recommendations in our upcoming sessions, we can you can comment it down or pin it down. So the quote we live from is: discretions, objections, delight in mockery, carefree mistrust are signs of health. Everything unconditionals belong to pathology. Friedrich Nietzsche. That's it, guys. Thank you for staying with me. Who are staying with me, thank you. And also don't forget to subscribe.